good morning to everyone that has joined today for our radiology rounds titled Cerebrovascular Anatomy and Stroke. And our guest speaker today is Dr. Peter Fiester. Dr. Peter Fiester is an associate professor at the University of Florida, Jacksonville. And Dr. Fiester completed his medical degree at the University of South Florida in Tampa, then continued his radiology residency at University of Florida in Gainesville. In that same university, he also completed his neuroradiology fellowship at University of Florida. And Dr. Fiester also serves as the director of CT quality and is also an associate program director and has had a great interest in radiology education. If you can find him in Twitter, he posts excellent content on neuroradiology, and I really, really recommend that. Without further ado, Dr. Fiester, please take it away.
Well, thank you very much, Daniel. I appreciate that nice introduction, and welcome everyone. And I just want to say thank you to Health for the World for hosting me and allowing me to give this talk. And I'm going to be discussing stroke today, and I'm going to be discussing mainly in the context of intracranial circulation anatomy. So I like to have a very kind of clinical-based discussion about stroke that's mainly geared towards understanding cerebrovascular anatomy and how it plays such a major role in identifying and being proficient in stroke studies. So the learning objectives for today is to be able to identify and name the segments of the anterior intracranial circulation, identify and name the segments of the posterior intracranial circulation, and then to recognize some of the common imaging findings of specific small vessel mediated strokes on CT and MRI exams, which are good for the resident to recognize and be aware of. So before we begin, I have kind of a short introduction for a few slides. I just want to take the time to say that, stroke is a clinical diagnosis. It's not a radiologic diagnosis. So that being said, what is our role as imagers in the setting of stroke? Well, first, you need to confirm whether or not an ischemic event has occurred, imaging-wise. If it has, you want to define the basis and extent of that stroke. And then after confirming that, you want to identify any contraindications to treatment. And those being mainly, is there evidence of acute hemorrhage? Has there been already a hemorrhagic component to the stroke? And then the second main thing is there a substantial area of infarction that you see on CT imaging? Is the area of infarction so large that you run the risk of potential hemorrhagic transformation? And then finally, you want to exclude other lesions and other explanations for the patient's clinical symptoms, the so-called pseudostroke type clinical presentation. And it's important to know that stroke has a very broad differential diagnosis clinically. There's many different pathologies that can mimic stroke. One of the most common would be seizures, but you can see from this list that other pathology, drug-induced encephalopathies, metabolic disturbances, migraines can sometimes mimic stroke-like symptoms. Focal visual deficits, such as optic neuritis, and then of course, brain tumors, underlying hemorrhage, and even press. So one of the main roles of the radiologist is to exclude these other potential diagnoses that could be mimicking a stroke in patients. So just before we begin, this is a nice case. This was a stroke alert called on a patient, and this patient was having left-sided deficits, and they ended up getting a brain MRI for a suspicious area in the right frontal lobe. And this patient turned out to have a cortical and subcortical mass with some internal enhancement within it. This was an oligodendroglioma, so a brain tumor presenting as a pseudostroke or presenting as an acute stroke-like presentation clinically. So important to know that these pathologies exist and something that, as radiologists, we need to exclude. All right, so that little short introduction being said, so cerebrovascular anatomy. So we need a detailed knowledge of intracranial arterial anatomy. It's really critical. And our role as a radiologist is, once we confirm that an ischemic stroke has occurred on imaging, is to do our best to try to match the anatomic location of the stroke to the vascular territory. And of course, in order to do this, we need to know our vascular anatomy. And just as a side note, it's important to know that no two strokes are really alike. And what do I mean by that? So when you have a cerebrovascular hypoperfusion event, when does that actually cause a stroke that shows up on imaging? Well, there's 4 factors that play into that. So the first is the depth of the stroke. So how severe is the hypoperfusion or oligemia? Is it a low grade or is it a high grade oligemia? Does the heart stop pumping, or is it something that's more insidious and kind of slow and gradual in onset? Number 2 is the duration. You hear a lot about time equals brain, which is absolutely correct. So the longer the hypoperfusion event occurs, no matter if it's low or high grade, the more likely a stroke is going to show up on imaging. Thirdly, collateralization. So every patient has a different degree of collateralization, and the main areas of collateralization for stroke is how much blood flow are they getting through their circle of Willis, how much blood flow are they getting through more peripheral leptomeningeal vessels and arteries along the cortex, and then does the patient have existing comorbid vascular stenoses that are going to put them at increased risk for stroke. And then finally, the 4th thing is autoregulation. So how much autoregulatory reserve do you have to dilate your arteries in the setting of a hypoperfusion event? So these 4 factors, depth, duration, collateralization, autoregulation, are what determines when a hypoperfusion event actually becomes a stroke on brain imaging. Okay, so that being said, we have that introduction under our belt. Let's talk a little bit about the cerebrovascular anatomy. So this is a depiction of the anterior intracranial circulation. It's the main conduit of the anterior intracranial circulation. It's our internal carotid artery. And conventionally speaking, I think the most recognized way to divide the internal carotid artery is through this 7 subsegment type of depiction, in which you have a C1 through C7 subsegment component to the internal carotid artery. And just to begin with, we'll start with C1. So C1 is your cervical ICA segment. So it's the portion of the ICA which extends from the carotid bulb superiorly to the skull base. And the cervical ICA has no vascular branches that arise from it. So that's probably the most important thing to know if you weren't aware of that already. So that's the C1 segment. The C2 segment is the petrous segment. So this is the portion of the internal carotid artery that is actually in the skull base. It's going through the internal carotid, the carotid canal. And there's subsegments to it. So it has a kind of medial and anteriorly projecting course as it goes through the skull base and through the carotid canal. And it has 2 arterial branches. It has the Vidian artery, which is sometimes referred to as the artery of the pterygoid canal. That actually anastomoses with external carotid artery branches of the face. And then it also has the carotid tympanic artery. And the carotid tympanic artery is an artery that supplies the middle ear. So important to know that those 2 arterial branches exist on the C2 petrous ICA segment. And just to drive that point home, so this is a cartoon depiction. So this would be our C1. So that's our cervical part, where the ICA enters the skull base. It has a kind of a posterior genu, and then it has this long horizontal component that goes medially. And it has a carotid-tympanic arterial branches. Again, there can be anywhere from 1 to 3 branches that go back and supply the middle ear cavity. Then it has an anteriorly projecting branch, which is the artery of the pterygoid canal, which goes through the Vidian canal and anastomoses with external carotid artery branches. So just to familiarize ourselves, so a CT scan, so this is our carotid canal. This is where the petrous ICA segment is going to be traversing as it goes from extracranial to intracranial. It has this genu this posterior genu, and it courses medially and anteriorly as it goes more distal. And just for completeness sake, so this is the Vidian canal. So this is the tiny little canal where the Vidian artery, or the artery of the pterygoid canal, is going to traverse, it's going to go through here, and it's going to anastomose with branches of the external carotid artery. Okay, so that's the C1 and C2 segments. There's a very short segment called the C3 segment, and sometimes referred to as the lacerum segment. This segment is actually covered by the trigeminal ganglion, and it's the first very short intracranial segment of the ICA. And just important to know that this segment exists and that there's no vascular branches arising from the lacerum segment. So the lacerum segment is a very short segment that's denoted right here by the arrow, and it's covered again by this trigeminal ganglion right here. So this is going to be kind of the first segment that arises as you exit the carotid canal. As you move more distally, you have the C4 segment, which is the cavernous segment. The cavernous segment is probably the most complicated anatomically speaking because it's divided into multiple subsegments. So you have a vertical ascending component, which is the first segment. And then you have a posterior genu. Genu just means bend. It's where an artery bends. You have a horizontal subsegment, which is the longest segment. And then you have another bend. You have an anterior genu. And then the fifth segment is the anterior vertical subsegment, sometimes referred to as the subclinoid ICA segment because it's immediately inferior to the anterior clinoid process. All right, so there's two main branches that come off the C4 cavernous ICA segment that are important to familiarize yourself with. There's the meningohypophyseal trunk, and the meningohypophyseal trunk actually arises from the posterior genu, so one of the more proximal components. It actually supplies portions of the pituitary gland, the tentorium, and the clival dura. And then there's a second branch, the inferolateral trunk, and this actually arises from the horizontal subsegment, and that helps supply the cavernous sinus dura and the cranial nerves which are traversing the cavernous sinus. So let's go back and look at our picture. So this is the posterior genu of the cavernous or C4 ICA segment. And then you have a long horizontal subsegment, which is this segment. And this cartoon depicts the position of the meningohypophyseal trunk coming up and supplying portions of the pituitary gland. And then also the inferolateral trunk, which arises slightly more distal and helps supply the cavernous sinus dura and the cranial nerves which are traversing the cavernous sinus. And then as you move a little bit more distal on the C4 segment, you have the anterior genu, and then you have this ascending vertical segment. And you can see that this is the subclinoid component of the cavernous segment because here you have the clinoid process right here. So there's another very short segment, the C5, or sometimes referred to as a clinoid segment. And this segment is actually where the internal carotid artery is passing between the two dural reflections that envelop the cavernous sinus. So there's a proximal and a distal dural ring of the cavernous sinus. And this segment is the segment that exists between these two dural rings. And this ends as the internal carotid artery will then become subarachnoid in location near the anterior clinoid process. Normally, no branches exist at this clinoid C5 segment, but occasionally there's an anatomic variation in which the ophthalmic artery will rise more proximally within the C5 segment. And it's important to know that this segment exists because from a neurosurgical perspective, whether or not an aneurysm or a vascular issue arises within this segment or potentially proximal or distal is important because it means more anatomic dissection because of the dura that exists here. Okay, so the C5 segment would be a really short segment just beyond the cavernous ICA, right adjacent to the anterior clinoid process. All right, so as we rise above the level of the anterior clinoid process, you have your so-called supraclinoid ICA. And a supraclinoid ICA actually consists of two segments. There's an ophthalmic segment, And the ophthalmic segment, of course, is named for the ophthalmic artery, which is the main artery to know that arises from this area. So this is going to come off anterior superiorly from the ICA at the C6 segment and go through the optic canal. And then the other branch is the superior hypophyseal artery. And the superior hypophyseal artery, in contradistinction, is going to go posteriorly. And it helps also supply the anterior pituitary gland, the pituitary stalk, and a little bit of the optic nerve and chiasm. So this is the position of the ophthalmic segment of the ICA. If you look carefully, you can see the ophthalmic artery, which is coming this way and going through the optic canal. And then you're also going to have the small superior hypophyseal artery, which is going to come off posteriorly and help supply the pituitary gland and then the pituitary stalk. Okay. Last segment. So this is the C7 segment. This is also known as the communicating segment. It has two major branches. It has the posterior communicating artery, and it has the anterior choroidal artery. So we'll talk a little bit about the posterior communicating artery more at the end. But the anterior choroidal artery is an important artery to know. So this is the position of the anterior choroidal artery. So this is kind of the termination of the ICA right here, sometimes referred to as the ICA terminus. The anterior choroidal artery comes posteriorly off the ICA terminus and has two parts to it. It has a cisternal segment, which passes within the crural and ambient cistern as it wraps around the midbrain. And then it has a lateral bend, and it bends and goes laterally. And sometimes this is referred to as the plexal point. And then it has a second component to it, which is the ventricular segment, which is actually going within the ventricle where it anastomoses with branches of the posterior choroidal artery. So why am I harping on this tiny little vessel? Well, there's a specific kind of stroke that can occur with the anterior choroidal artery. And it's important to know that given the unique kind of anatomy of the anterior choroidal artery, that it can cause a stroke in the mesial temporal lobe, and it can also cause a stroke within the posterior limb of the internal capsule and the lateral thalamus, and sometimes even cause a visual disturbance because of its vascular supply to the optic tract and radiation. So what does that look like on imaging? So this is an example of an anterior choroidal artery stroke. So this is a stroke that's focal, involving the mesial temporal lobe and also involving the posterior limb of the internal capsule and maybe a little bit of the lateral thalamus. So this distribution of stroke, if you see this, is characteristic of an anterior choroidal artery stroke, which arises again from the terminus of the internal carotid artery. Okay, so that was our discussion on the internal carotid artery, the 7 segments. So we'll move on to the internal carotid artery bifurcation. So of course, the internal carotid artery is going to bifurcate. It's going to bifurcate into the anterior cerebral artery and the middle cerebral artery. So we're going to talk first about the anterior cerebral artery. So the anterior cerebral artery conventionally has 3 segments to it. It has an A1 segment, and the A1 segment is a very short segment. It comes up from the ICA terminus to the anterior communicating artery. You have the A2 segment. The A2 segment extends from the anterior communicating artery to the origin of the callosal marginal artery. And then you have, most peripherally, you have the A3 segment. And the A3 segment is distal to the origin of the callosal marginal artery. All right, so let's take these one at a time. So the A1 segment. So this little cartoon depiction is depicting in red the position of the A1 anterior cerebral artery. So here we have the ICA terminus. It's bifurcating into the anterior cerebral artery on one side, the middle cerebral artery on the other. And this short segment, as it goes from the ICA terminus to the anterior communicating artery, is the A1 ACA. So you may ask, well, are there any important branches? Well, there actually are. So you have medial lenticular striate artery branches. And these are these little perforating arteries that come up and are going to supply the anterior and inferior portions of the internal capsule, can supply the anterior and inferior portions of the basal ganglia. And there's a specific named artery that exists in this location, and it's referred to as the recurrent artery of Heubner. And this is really just a dominant medial lenticular striate artery that arises from the A1 ACA. And the reason I bring up the recurrent artery of Heubner is that it has a specific characteristic appearance when there's a stroke of this artery. So just to give you a different look at the anatomy, so this is the anterior communicating artery. And in this depiction, it actually is coming off the A2 anterior cerebral artery. So it can come off the A1 segment, or it can come off just along the proximal A2 segment. And actually the proximal A2 segment's more common, as in 90% of cases. And this recurrent artery of Heubner is going to kind of make a hairpin turn. It's going to parallel the course of the A1 ACA, and it's going to come back and it's going to supply the head of the caudate and the anterior and inferior internal capsule. So this is the characteristic location of a recurrent artery of Heubner stroke. So focal stroke within the head of the caudate, as you can see here, and then chronic appearance of a recurrent artery of Heubner stroke. And again, this is another brain MRI diffusion weighted sequence, which we have restricted diffusion that correlates with the head of the caudate in a patient with hemiparesis of the face and upper extremity. And this is characteristic appearance of the recurrent artery of Heubner stroke. Occasionally, you'll see in the setting of an anterior communicating artery aneurysm that's been clipped, the inadvertent sacrifice or sometimes occlusion of the recurrent artery of Heubner, in which you'll have an aneurysm clipping in this region, and then you get this as an unintended consequence, a recurrent artery of Heubner stroke. So that's sometimes the clinical context you'll see that in as well. Okay, so as we move more distally along the A2 ACA, there's two more name branches to be familiar with. There's an orbital frontal artery, which comes off here. This is the orbital frontal artery, and then it bifurcates into multiple cortical branches. It supplies the gyrus rectus along the inferior frontal lobes. Then you have a frontal polar artery, which is an artery that comes off and supplies the mesial portions of the frontal lobe here. So those are two name branches along the A2 ACA. Now at this point, where my arrow is, you extend up the A2 ACA, and then it actually bifurcates and it becomes the A3 ACA. And the A3 ACA is sometimes also known as the pericallosal artery. The pericallosal artery is this artery, which is running within the sulcus of the corpus callosum, right on top of the corpus callosum. And then it has another branch that comes off superior to it, which is known as the callosal marginal artery. And the callosal marginal artery runs in the cingulate sulcus, so just above the pericallosal artery. So again, so this is considered the callosal marginal artery is the A3 ACA. I just wanted to include this interesting case. So this case teaches a couple points, but one, this is a non-contrast head CT. We have a hyperdense pericallosal artery. What does that mean, hyperdense? It means there's clot, there's retracted clot within the pericallosal artery. Patient gets a CTA that shows that the pericallosal artery is occluded, and then presents with a right-sided stroke in the pericallosal artery territory. So main point is that you can get a hyperdense artery anywhere, not just your MCAs. And two is if you kind of correlate where a stroke occurs, you can work your way backwards and find out, you know, the likely vessel that was involved in the CTA. Okay, so the other bifurcated branch of the ICA terminus, of course, is the middle cerebral artery. The middle cerebral artery conventionally has 4 segments to it, and important to know all of them. So you have the M1 segment, which extends from the ICA terminus to where the middle cerebral artery is either going to bifurcate or occasionally trifurcate. You have an M2 middle cerebral artery, which is sometimes known as your insular segment. And this is the bifurcated or trifurcated branches that extend into the circular sulcus of the insula. And then you have an M3 segment of the MCA, and this is where there's a hairpin turn that the MCA generally makes. And sometimes it's called the opercular branches, and these exist within the sylvian fissure. We'll see a picture of that in a second. And then finally, the most peripheral branches of the MCA are referred to as your M4 MCA branches. And these are the branches that emerge from the sylvian fissure and extend along the convex surfaces of the hemisphere. And sometimes these are referred to as cortical the cortical segment. All right, so this is your ICA terminus that's cut. And then we get into our M1 MCA segment right here. As we extend more peripherally, the MCA generally bifurcates, occasionally trifurcates in about 15% of cases, and it goes into the circular sulcus. And these are the M2 branches. There's generally a superior and inferior division. And then it makes a hairpin turn, and these are referred to as the M3 MCA branches. And as it exits the sylvian fissure, you have these cortical M4 MCA branches. So let's concentrate first on the M1 MCA. So as this cartoon depicts, there's multiple of these perforating lenticulostriate arteries, the lateral lenticulostriates, that come up and are going to supply the perforating substance, the internal capsule, the basal ganglia. So it's going to be your main basal ganglia vascular supply is going to arise from these M1 MCA vessels. And just to give you another kind of depiction of the number of vessels that come up and how they perforate into the basal ganglia on the right side. So these are crucial vessels. So how does this translate into our imaging? So these are examples of M1 MCA strokes. And it's important to know that if you are going to have a stroke that occurs in the proximal M1, you're going to have characteristic involvement of the basal ganglia just by the fact that you're going to occlude those lenticulostriate arteries. If you have an M1 stroke that is a distal, it typically is going to spare the basal ganglia since it's going to spare the majority of lenticulostriate vessels. So in this picture, you can see that the cytotoxic edema is involving the basal ganglia. And in this one, it's sparing the basal ganglia. Now, why is this helpful? So it's helpful to know this because one is when the patient gets a follow-up vascular study, you're going to have a pretty good idea of where to look for the vessel occlusion, depending on the anatomic extent of the stroke. Okay, so then as the MCA bifurcates or trifurcates, there becomes a superior and inferior division. And occasionally there's a central and middle branch that occurs too. And I think it's best to look at the M2 MCA branches on a sagittal because this is where you get the anatomic delineation, which branch is superior and which branch is inferior. So you have the MCA bifurcation right here. And then you know that the more superior division or the more superior vessel that comes off is going to be our superior trunk, and that the more inferior position one is going to be our inferior trunk. So it's important to know that this relationship exists between the superior and inferior branches. And the reason being is that depending on the medium vessel occlusion that's occurring, they're going to occur in different anatomic locations in the brain. So if you have a M2 superior division stroke, the majority of the stroke is going to be located anterior to the sylvian fissure. So if you have a stroke in this location, you know exactly where to look on the vascular study to determine where the vessel occlusion is, almost without looking at it. If you have an inferior division stroke, the majority of the stroke is going to be located posterior to the sylvian fissure, as you can see here. And it's important to note too that these do not necessarily present with a motor or sensory deficit when you have an inferior division stroke, even with such a large stroke. So you typically have visual field deficits and a receptive aphasia with inferior division strokes. Okay, so just for completeness sake, these are our M3 MCA branches, which are descending inferiorly. And then as it exits the sylvian fissure, it becomes the M4 cortical branches. So examples of cortical branch infarcts are going to be the infarcts that are going to be more peripheral, generally smaller, oftentimes extend to the convexity. You know that these strokes are generally going to be very small vessel occlusions, not the type of occlusion you're typically going to see on a vascular study per se as a completely occluded vessel because they're so peripheral within the brain. So I just want to make one point is that, you know, as I've become an attending and looked at so many strokes already, you know, it's a good idea as a resident to, whenever you have a stroke on a brain or an obvious stroke with early ischemic change on head CT, go back and look at the vascular study if the vascular study was done first. And you will start to pick up very small vessel occlusions that may not be the most obvious. So this is a patient with a right operculum stroke. It's just a small focal stroke in the operculum. And then if you go back and you look at their vascular study, you see that there's a very small branch vessel arising off the superior M2 MCA that has got a little clot in it. And if you start with this, and then as practice, go back and look at the vascular study, and you do this for all your strokes, you will become very, very good at reading these CTAs. So I think that's a nice thing to in order to learn vascular anatomy. Okay. So that was anterior intracranial circulation. So we're going to talk a little bit more briefly about posterior intracranial circulation. So just to give an overview, I think most people are familiar through medical school of this picture. You have your vertebral basilar circulation, of course. You have your two vertebral arteries, which are ascending. They give off a conjoined anterior spinal artery off the distal segment. That there's generally going to be a small pica vessel that is coming off the distal vertebral arteries on your side. You're going to have generally an ICA vessel that is coming off along the proximal basilar artery. And then as you ascend, you have all these tiny little perforating vessels, which are going to supply your pons on either side. And it's important to know that they occur on either side, as we'll see in a second. And then as you keep going more superiorly, you have your superior cerebellar arteries. And then of course you have your posterior cerebral arteries, which come off as the basilar artery bifurcates. So I want to talk a little bit in the context of the cerebellum and vascular supply to the cerebellum, because I think a lot of times this is, maybe overlooked or not well understood by some, and it's really not that complicated if you break it down. So if you just look on this image and you look at the three surfaces of the cerebellum, that there is a occipital surface to the cerebellum. This is the portion of the cerebellum that contacts the occipital bone. There is a petrosal surface of the cerebellum, where the cerebellum contacts the petrous portion of the temporal bone. And then there is a tentorial surface to the cerebellum, where the cerebellum contacts the tentorium. The tentorial, occipital, and petrosal surfaces of the cerebellum all have a distinct vascular supply. The occipital surface of the cerebellum is supplied by the pica. The petrosal surface of the cerebellum is supplied by the ICA. And the tentorial surface of the cerebellum, which is the largest portion and is the majority of the superior half of the cerebellum, is supplied by the superior cerebellar artery. And this is just a cartoon representation kind of showing us the same thing. So pica territory along the occipital surface, ICA territory along the petrosal surface, SCA territory along the tentorial surface. So if you have a stroke that abuts and contacts majority of the occipital surface, you know that you're dealing predominantly with a pica vascular territory stroke. So this is an example of the pica vascular territory. The pica is also going to supply the cerebellar tonsil. It's going to supply the posterior lateral medulla, which we'll see in a second. But this is a predominant pica vascular territory stroke. So the ICA supplies the middle cerebellar peduncle, which we'll see in a little bit. It supplies the inferolateral portion of the pons and the flocculus and the petrosal surface of the cerebellum. And this is important to know as well. So there is an ICA-pica coronary artery type relationship where you're generally going to have either a large pica and a small ICA, or a large ICA and a small pica, and you can actually have the anterior inferior cerebellar artery arise off the posterior inferior cerebellar artery. So there's this weird kind of coronary artery relationship, this reciprocal relationship between these two vessels. So this is an example of an ICA vascular territory stroke. So this is your middle cerebellar peduncle, normal on the left side. This is the right side. And you know if you have a stroke in your middle cerebellar peduncle that you have an ICA vascular territory stroke. And similarly here, is just like that cartoon we showed in us, or that shaded MRI we showed a little bit earlier. So this is the petrosal surface of the cerebellum. So this is all ICA vascular territory. And then finally, the superior cerebellar artery. So the superior cerebellar artery, like we mentioned, supplies the superior surface of the cerebellar hemispheres all the way down to the horizontal fissure, which is the predominant fissure that divides the upper and lower halves of the cerebellum. So this is also sometimes referred to as the tentorial surface of cerebellum. It also is going to supply the superior vermis, the dentate nuclei, most of your cerebellar white matter, and even part of your midbrain. And this is important to know. The superior cerebral artery should be accounted for in all vascular studies, mainly CTA studies. It's rarely absent. So if you have a superior cerebral artery, so this first is the basilar artery. You have the superior cerebral arteries coming off both sides. You have the PCAs coming off both sides. And then this is an example of, all right, we're going to follow the basilar artery up. There's no superior cerebral artery on this side. If a superior cerebral artery is absent, it's occluded. So you should always see your superior cerebral artery. And this was a case where you have occlusion all throughout your superior cerebral artery. You even have some clot hanging out in the basilar artery. So this is never normal to have a quote unquote absent superior cerebral artery. And this is in, in contradistinction to the ICA. You're not necessarily going to see the ICA on every single study because of that reciprocal relation. We've seen it can be very small. Sometimes it can arise from the pica and can be difficult to see. The superior cerebellar artery is a consistent artery you should be able to see on all CTAs. And this is the characteristic location of a stroke that involves the superior cerebellar artery vascular territory. So why? So first, it abuts the tentorial surface of the cerebellum. It's located above the horizontal fissure, the upper half of the superior cerebellum. So you know that when you look at your vascular study, you're looking at your superior cerebral arteries very closely to see there's an occlusion within it. So characteristic SCA infarct. Okay, so that's the cerebellum, those three surfaces, those three vessels. So let's talk a little bit about your brainstem. So we'll start first with the medulla. So there's two specific small infarcts that have large clinical consequences. So the first, and probably the more commonly recognized, is the lateral medullary syndrome. So lateral medullary syndrome is an infarct that occurs in the posterior lateral medulla. And this is going to be the characteristic location. And this is typically an infarct of the pica, because we said that the pica, which not only supplies the cerebellar tonsil here, it's also going to supply the posterior lateral medulla. These are overwhelmingly going to be the consequence of vertebral artery dissections in which the pica, which arises off the vertebral artery, becomes occluded. And you have some degree of collateralization, which is going to spare the more peripheral pica territory, and you just get these little proximal infarcts that give you this lateral medullary syndrome. And just from a neurologic point of view, so again, it's an occlusion of the intracranial portion of the vertebral artery and followed by the pica and its branches. These are the symptoms: vertigo. Then characteristically, it presents with loss of pain and temperature sensation on the contralateral side of the stroke, but will occur with ipsilateral bulbar muscle weakness on the same side of the stroke. So hoarseness, dysphonia, dysphagia, dysarthria, cranial nerve, lower cranial nerve mediated deficits. So in comparison, this is an example of the so-called medial medullary syndrome. And I like to throw this one in there. So this is a stroke that involves the ventral surface of the medulla. Now, this is not pica territory. This is not where pica supplies. This is actually an occlusion of little small perforator branches that come off the vertebral artery or the proximal basilar artery, and they supply the medial aspect of your medulla. And this is another one of those strokes, this little medial medullary syndrome, which has large clinical consequences. You get a contralateral hemiplegia, hemiparesis, you get a hemisensory loss, and a ipsilateral cranial nerve 12 palsy because of the cranial nerve 12 nuclei involvement. So important to know. So this is not going to be pica. This is going to be little perforators off your vertebral artery generally. Okay, so that's medulla. Let's talk a little bit about your pons. So the pons, when you're discussing strokes in the pons, you got to discuss your basilar artery. So the three primary mechanisms for basilar artery strokes, so thromboembolic disease, atherosclerotic disease, and occasionally propagation of intracranial dissection. And the only reason I'm harping on the mechanism for basilar artery strokes is that depending on what part of the basilar artery is involved, the mechanism can typically be a little bit different. So if you have a stroke or an occlusion that involves the distal third of your basilar artery, sometimes referred to as the basilar tip, those are overwhelmingly going to be thromboembolic and sometimes present as the top of basilar syndrome, which we'll see in a second. If you have more of a proximal vertebral basilar artery stroke, where it's a proximal basilar artery occlusion, you have to worry about not only thromboembolic disease and atherosclerosis, which is the same as the midsegment, but also could this possibly be from a propagation of a vertebral artery dissection? So if you're proximal, dissection becomes more of a concern. If you're distal, more likely to be thromboembolic. So this is the characteristic location of a basilar artery perforator stroke. And the reason I included this case, is a little bit of an older case, is to show you that how strikingly one-sided it is. Basilar artery perforator strokes will always respect midline. They will not cross to the other side and involve both sides. That is extremely unusual. And it's because those little perforators come off on either side of the basilar artery and perforate into and supply the pons. It's important to know because there's a lot of other pontine pathology, such as central pontine myelinolysis, pontine gliomas, that are typical more with a central and bilateral involvement. So if you understand that a basilar artery stroke, whether it's acute or chronic, will respect midline, that is an important point to know. So this is just another example. So this was a perforator stroke of the basilar artery. And again, strikingly symmetric, only affecting one side. And the mechanism here was the fact that they had a actually partially thrombosed basilar artery aneurysm that had picked off one of the perforating vessels. And you can see the restricted diffusion. And again, the striking midline respect that it has. It does not cross midline. Okay, so then we'll talk more about this so-called top of basilar syndrome. So like we talked about, this is more likely to be a thromboembolic process. You can see on this angiogram, this crazy looking, just acute cutoff and meniscus sign in which there's no contrast filling past the distal tip of the basilar artery. This is the CTA appearance of it, in which you get focal clot that's just localized within the distal basilar artery. Sometimes it can extend slightly into the bilateral PCAs. And the imaging appearance of the top of basilar syndrome is going to be this so-called bat wing appearance, in which it has kind of a winged shape as it involves the, in this case, the midbrain. But more inferiorly, it can also involve your pons. And unlike those perforator strokes, this is typically midline. It can be really strikingly symmetric, but it typically involves the midbrain and is going to have this bat wing distribution. So this is almost pathognomonic appearance for the top of basilar syndrome. And I want to draw a distinction here with another type of stroke that is very rare. You see it occasionally, and that's this artery of Percheron stroke. So it's important to note that at the tip of the basilar artery, there are these multiple little tiny perforators. And this is the conventional anatomy in most people, that they have little tiny perforating vessels that arise here. In the minority of individuals, there is one single artery called the artery of Percheron that arises near the tip of the basilar artery that then gives off multiple tiny little perforating vessels. So the risk is in these individuals who have this artery of Percheron variant in anatomy is that if you thromboembolic and occlude the artery of Percheron, you can actually get a fairly significant stroke. So just on MRA showing that this is these multiple little perforators that come off in normal conventional people. The anatomic variation is the artery of Percheron, which is a single vessel that gives rise to all the perforators. And occasionally there's actually an arcade that can exist in which you have a redundancy in the origin of these perforating vessels. And that's occasionally seen as well. So this is an example of the location of an artery of Percheron stroke. It is very small, it's very focal. It typically involves kind of the hypothalamus and inferior thalamus. And it's almost never called on head CT. It's very difficult to see on a head CT. It's generally picked up on a brain MRI. And it presents with this triad of altered mental status, vertical gaze palsy, and memory impairment. So just be aware that that is an artery of Percheron stroke if you have this appearance. Occasionally, you can have internal cerebral vein thrombosis kind of mimic this. In my experience, it's typically a little bit of a larger area of involvement when you have that. But this is fairly characteristic for a AOP stroke, artery of Percheron. So just to draw a distinction between the two, so again, artery of Percheron stroke, symmetric, bilateral, more thalamic, hypothalamic in location. Top of basilar stroke is the clot within the distal basilar artery. It has more of a batwing configuration as it involves the two cerebral peduncles and the rest of the dorsal midbrain, and then also affects the pons in kind of a more symmetric, generalized location. Okay, almost done. All right, so I just want to give a quick overview of the posterior cerebral artery. So just for completeness sake, there's 4 conventional segments to the PCA. You have the P1 segment, which is going to be the short segment, which extends from the basilar artery to your PCOM, posterior communicating artery. The main branches that come off your P1 PCA are going to be your thalamoperforators. Also important to know that thalamoperforators also arise from your posterior communicating artery as well. Your P2 segment, which is going to be the posterior communicating artery, just distal to that as it wraps around the midbrain. And it's actually subdivided into 2 segments. There's an anterior component to it and a posterior component to it. The anterior component of the P2 PCA lies within the crural cistern as it wraps around the more anterior portion of your cerebral peduncle. The posterior component is located within your ambient cistern as it comes more along the lateral midbrain. The perforating vessels here are your thalamogeniculate perforators. You have lateral midbrain perforators, which help supply the lateral portions of your midbrain, and also your posterior choroidal artery. Okay, and then as you move more peripheral, you have the P3 PCA segment, which is your quadrigeminal segment, named for, of course, the fact that lies in the quadrigeminal plate cistern. And then it's, again, a very short segment. And then you have your P4 segment, which is going to be your cortical segment. So as the P3 rises above the level of the tentorium, it becomes your P4 segment. And then there's a couple of named arteries, the calcarine artery being one of them, that lies within your calcarine fissure that supplies your occipital pole. So just for completeness sake, so again, our basilar artery, we have our P1 PCA, which extends from the tip of the basilar artery to your posterior communicating artery, has these little tiny thalamoperforators that are coming off, and then of course thalamoperforators that come off your posterior communicating artery. And then as you move distal to the PCOM, you have your P2, A, and P segments, which are going to give off your thalamogeniculate perforators, your midbrain perforators, and your posterior choroidal artery. So one way to think of PCA blood supply is to just take a look at, this oval is the representative of your thalamus. Now, this is your ICA terminus. This is your PCOM. This is your PCA. And just look at all the redundant vascular supply to the thalamic region. So you have thalamoperforators off your PCOM. You have thalamoperforators, which are going to arise off P1 PCA. You have the thalamogeniculate branches off your P2 PCA. So the thalamus has a predominant PCA supply. And even your posterior choroidal artery, which arises more off your P2P segment, is going to give a little bit of vascular supply typically to your thalamus. So very redundant, very PCA predominant blood supply to your thalamus. And then again, just for completeness sake, you have your P3 segment, which is going to lie in this region, which is going to be in your quadrigeminal cistern. It's going to rise above the level of the tentorium and is going to give off your parietal occipital artery, your calcarine artery, and supply your occipital pole. All right, and that about wraps it up. So hopefully, the objectives we try to learn today was to identify and name the segments of the anterior intracranial circulation, hopefully identify and name the segments of the posterior intracranial circulation, And then, you know, put this cerebrovascular anatomy in the context of stroke and hopefully recognize some of the common imaging findings of specific small vessel mediated strokes on CT and MRI. So that is it. Thank you very much for everyone's attention.
Dr. Fiester, thank you so much for the comprehensive anatomical review, and I really enjoyed the clinical correlation that you were giving us with the case presentation. We have one question that reads the following. I would like to know if is it obligatory to have cerebellar symptoms with cervical medullary infarction?
So if you have a stroke in your cervical medullary region, generally you're going to get more paresis and sensory deficits. That is kind of the typical presentation. And of course, depending on the level of brainstem involvement, you know, where the decussation occurs in the medulla, if it occurs below or above it, it's going to determine what side the symptoms are generally on. But those are very rare infarcts. So I'm thinking more like the medial medullary syndrome. A focal medulla infarct is very rare and obviously catastrophic if it's large enough. So, and typically the cerebellar symptom infarcts are related to more of the, you know, ICA, SCA, pica vessels.
Right. Well, thank you so much. We are getting many thank you messages in the general chat. And thank you once again for your time, for being here, for teaching us, and the attendings for joining today.
Yeah, thank you, Daniel, for moderating, and I appreciate it very much. Hope everyone enjoyed it and learned something new. Of
course, we would love to have you again in the future.
Will do. Sounds good.
Bye, all.